So good afternoon, everyone. So today we have the 15th session of FCPC program. So today we have our eminent faculty, Dr. Emma Rajagopal. So let me have this privilege to introduce our faculty today. He's a director of the WHO Collaborating Center at Trivandrum and the founder chairman of Palim India. His initiatives to remove regulatory barriers and availability of oral morphine for pain relief have contributed to simplification of narcotic regulations in 17 of India's 29 states and more recently to the amendment of the NTPS Act of India. His initiative has also contributed to the development of government policy on palliative care in the state of Kerala in 2008 and Government of India's National Palliative Care Strategy in 2012. The international organization Human Rights Watch honored him with Alison Des Spots Award at Los Angeles in November 2014. In 2017, a documentary film titled Hippocratic 18 Experiments in Gently Shaking the World, based on Dr. Rajagopal's contributions to palliative care, was released by Moonshine Agency, Australia. In 2018, Dr. Rajagopal was honored with Padma Shri, the third highest civilian award given annually from Republic of India. In 2022, published his memoir Walk with the Weary. So I would like to take this privilege to welcome you, sir, for the session.
Thank you, Devika. Hello, Sangeet. And everybody, good afternoon to you. I want a favor from you. No, we're not yet. Please stop the share. I'll
Yes, sir.
call out. I want a big favor from all the participants. Please switch on your videos. Virtual education is a misery as a whole, and especially it is so gloomy to address a screen full of black rectangles. The least we can do is to interact with people so that I can see some smiles. Whatever faces are visible are very grim. Some smiles for me, please. Oh my God, we are in a group where smiles are so... Yes. Puvarsan. Thank you. A very forced smile, but at least a smile. Yes. So, friends, I'm so glad to have this opportunity to talk to you. Shall I wait for another minute to see if some more people who can quickly apply makeup and come back can also join with the video? Kavita, Trisha, Arpita, Shivakumar, Sudeepta, Simran, Prince, Reshma, Vishwaranjan. Okay, some people. That's a lot better. Very good. I feel a sense of achievement now. I know. Some people will have poor connectivity. Friends, we have an important topic to talk about. And I fear I'll have to start with some difficult questions to you. I hope you will forgive me for asking such difficult questions to an audience comprising of many young people. By the way, the link that I'm sure Sangeet will be sharing the whole presentation with you, because at some spots there are some important links. What you see here, the link below that image, that's supposed to be an image of death, by the way, is the Lancet Commission report on the value of death. Value of death. I would encourage you to read at your convenience, at least the executive summary. I think it's about 4 pages. Maybe you will want to then look at the key messages and some suggested course of action. So that will be a good background reading for what I am going to talk about. But I already gave you a warning. I am going to ask a difficult question. Oh, if I stop the share, Sangeet, will you administer the poll?
Yes, sir, sure.
Please tell everybody exactly what to do. If it has not been done before, some people may not be clear about it.
So we are going to launch the polls right now. You will see a screen in which you are asked one question. I hope the screen is visible to all. So you can answer to the question which you think mostly suits you or most appropriate for you.
By clicking on the answer?
Yes, by clicking on the answer. I request all participants to do attend to the polls right now. It will be open for another 40 seconds. Another 20 seconds. As for those who are not able to see the screen, at the bottom there might be an option called polls. Just click on to it. You will see the question.
Ashwati Vijay cannot see the poll.
While you're seeing the icons at the bottom, like participant, security, share screen, there's an option called polls. You can click on to more. You will find an option called polls. You just click on to it. You will see the question.
Anyway, okay, sorry. Devika, sorry, I interrupted you. Please continue. Devika, 35 people have so far answered.
Yes, sir. 30. Now it's 36. Yes.
Yeah.
I think
So,
80% of the participants.
So 50% of the participants have said yes, which is unusual, I must say. Most of the time, it's only about 1/3 of people who answer yes, but half of the audience are able to contemplate the possibility of one's own death. And fairly typical, 1/3 of people cannot. Even the thought is maybe frightening. And another 19% is not sure. That's also typical. Usually it's 1/3 of each. Why I asked the cruel question, I'm going to show you. Sangeet, shall I share my screen now?
Yes, sir.
And give it back to you when we get to the poll?
Yes, sir, sure.
And it's okay. This is, I spun it as a surprise. But I must tell you, it's a great strength to be able to think about your own mortality. Because if we know that our stay on this planet is fairly short, time limited, uncertain, that's the worst of it, uncertain, then once you have taken that in, you may be able to think, what do I want to do with my own life? The time can be anywhere from 5 minutes to 50 years or more. What do I do with that time? And then maybe if you sit down at some point and think about it, maybe your course of life may change. It may become more meaningful. You may be able to live it more meaningfully. And that may help us to do some planning so that that time when it comes, it's not as frightening as it is to 1/3 of people in the group now. And the second bullet, if when we accept our own mortality, we are able to better understand people who are dying. And then we are able to help them more. What I'm saying is, end of life care to someone else is easier when we know our own mortality, when we are able to face it. And please remember, when I said help others who are facing death, I am not only talking about the patients in your institution, I'm talking about all our loved ones, your grandparents, your parents, uncles, aunts, or others may also go someday. And that can be a very difficult time for them and for you. But if you are better prepared, that time will be easier. Maybe when you get home today or when you are at leisure, please give this some thought. Devika, as we go along, if there are any significant chats for which I must answer in between, please let me know. Interrupt me and tell me.
Sure, sir. Sure, sir. Sure.
Thanks. And right at the moment, dying is not easy in our country. Dr. Sankha Mitra is a British oncologist who works in Australia, earns money, lives on his wife's salary, and spends all his salary on palliative care in the Northeast because he feels things are really bad there, and we all agree. I haven't included that slide, but there is a study done based on Singapore, and they study the quality of death. It's called Quality of Death Index. If you Google for it, you will find it. And you will find that India is among the worst 20 countries in the whole world. They're among those studied where things are bad. As Sankha says, the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators. No one gets a pain-free and dignified death. Now, palliative care is not only for the dying. Of course, we all know that palliative care starts when any disease starts. If the disease gets cured, palliative care stops there. If the patient dies, palliative care does not stop. It continues as bereavement support for the family. But I won't ask that cruel question to you. This is was an inmate of a home that Devika possibly has been to in Trivandrum, where destitute sometimes are admitted. She was one of them. But we had to send the daughter some money so that she could afford to leave some food for the children and come over to see the mother taking a bus. But she died with some water going in her parched throat. Whereas everybody here, I'm not talking to the people who are not sure and who are not thinking about it. People who are able to think about it, think about this also. This could be the way we all end if we have any money in the pocket. More grim news. These are both fairly recent publications. The first panel on Europe is a study from European countries, European intensive care units. And they find that 90%, almost 90, 89 point something percentage of people, if they are in an intensive care unit, are taken off their life support systems and instead given palliative care. Whereas in India, 70% of people are continued on life support systems so that their death is stretched out. And I know as a former intensivist that life in an intensive care is not easy at all. It is torture all the way through. And when there is no return, that is really cruel. What I'm saying is, we learn intensive care from the West. We practice it. But we do not practice the compassionate part of their care. 70% of people are continued indefinitely on life support systems. Still, eventually the heart stops. And the other 30% are not given life support system, palliative care. They are generally taken off the ventilator, connected to an ambu bag, and the bag is given to a wife or a husband or a child and said, squeeze this 12 times a minute. They are forced to sign declarations saying that I am going against medical advice. I realize that it may cause my mother's death. I take full responsibility for it. And what kind of guilt will they live with forever? Friends, this is why I said things are very bad in India. Why am I making you all hear this grim news? Because, friends, we have to change this. And somebody else will not come and change it if you and I, who are exposed to palliative care, advocate for it and change it. I know that I have said some difficult things. I see, like, how many participants? 45? There must be at least 10 people in the group who have gone a major suffering from the death of a loved one in your own family. For many, that may not be an easy tale to tell. But if there is anyone in this group who has such an experience within the family and would like to share, Devika, with your permission, I'll take a couple of minutes off our final discussion time and spend it here.
Yes, sir. Sure, sir. Sure. Yes.
I know it is those who find it too emotionally overwhelming, you don't have to share. But for some, it may be actually cathartic to share the story. Please keep it short. But if somebody would like to share a personal experience, please do.
So we do have a response from Geeta Nair. She wants to share something of her
Yes.
experience.
Geeta, please unmute and speak.
So this was in 2014.
Sorry, Geeta, where are you from?
Sir, I'm from Mumbai.
Okay.
Sir, in 2012, my father was detected with cancer, and that was the last stage. So we were told that chemotherapy and all can work. So we did everything. But in 2014, we lost him. The last 1 week was like he was bedridden. He was not having any food or even water also. He had completely stopped. And it was very sad for us to see him suffer like that. But he was at home. Like the doctors in the hospital had said that you can take him home. And we also decided to bring him home. So he was with us only. And in the last moments also, the last night also, I was in the same room. And the next morning, he passed away. So that is, I don't know, even now I can relive each and every moment of the struggle. Like we did everything possible because he wanted to live. He saw all his children getting married and having grandchildren and everything, but still he wanted to live. But in the last 2-3 months, he had given up hope, and he had said that it is okay now. I don't want to be a burden on all of you. That was about my father.
Geeta, Even now you are suffering.
Yes.
9 years later, the wound is still there.
Yes,
People
but
think that
I feel why what did we do to lose him? So
Mm.
like we wanted him for more years. We all wanted.
So just see, friends, the wounds never heals completely. We just learn to live with it. Tida, very difficult for you to share this, but you shared it for our common benefit. I have respect for that and thank you very much. So I'll take one more. Jayanta.
Jayanta course would like to share.
Jayanta.
Yes, sir.
So as I said, keep it short. And after that, I'll move on. Yes.
Yes, sir. I'm from Kolkata, West Bengal, and it's about my father. He passed away in 2000, end of 2019. He was diagnosed with Alzheimer's, and he had multiple fractures. He had suffered from fall. He was staying with us. We stayed together. But in the last 10 days or so, he's suddenly started having convulsion. So we contacted our doctor, and he said that, see, this has to be treated in hospital. We took him to hospital. He was put on life support. The doctors or the specialists visited him. They did multiple tests, but ultimately in 3 days they came with the diagnosis that such a situation he is suffering from cannot be treated within their limits. So the treating doctor under whom he was admitted, he ultimately suggested that let us take off the life support and let him pass away. And initially, because of this Alzheimer's, we found that he was suffering a lot, and he was not in his actual persona. So my mother suffered quite a lot because we all stayed together, and he passed away in the hospital, and that is a sorry plight for all of us that we could not take him back to our home. And still now my mother sometimes shares that he could have lived a bit more. He could have lived longer. Uh, this is this much I want to share. Thank you, sir.
Jayanta, thank you very much. Thank you. And even more painful story than Geeta's. But both of them, Geeta's dad as well as your dad, what they deserved was care with dignity at the end, which is possibly why you are attending this course. People deserve comfort as far as possible in a place where they feel connected, like home, and they need compassion and care. So don't have to talk a lot because your sharing the experiences brought home to the whole team the importance of the two. Geeta's dad was luckier in that he could be home. Though possibly Geeta did not get palliative. Geeta's dad, there was no mention of palliative care, but Jayanta. And this, you must understand, is happening to a lot of people in our country. Now, I won't talk about you and your death anymore. I'm being cruel, but it's easier for me. Think of me in the position of that man, close to my end. Think from my point of view. That's empathy, isn't it? Trying to step into somebody else's shoes and thinking, what all would be important for me in the last month of my life? Was somebody speaking? Can't hear you. You can write in the chat box when you are unable to talk.
Yeah, make sure that there should not be any disturbances. You can use the chat box if you have any doubts or clarifications. Thank you.
Ashwati, I know you have a story in you. Maybe you can talk towards the end. If you feel up to it, Ashwati. You gave me a personal message. Thank you very much. Geeta, your dad was particularly lucky at home with loved ones. Maybe you felt the discomfort and that should have been helped with. But yes, most of you might feel that having loved ones around them would be more important than the latest instruments in the intensive care unit. A hand to hold, a kiss from a grandchild. Oh my God, when I think about my end, I would consider that the greatest blessing to get that kiss, a hug. Do you know of any intensive care unit who will allow children to be brought in so that a final kiss can be given? What our healthcare system now does is to sustain life, treat diseases, and at the end of life, a very difficult time of their lives, as Geeta and Jayanta will testify, at that time, they will deny me, I am afraid, of everything that is most important for me. That will be stolen from me. What would I need? Of course, I need to be physically comfortable, emotionally at peace, relationships maintained, spiritually calm. Somebody is trying to speak, but the voice is breaking. We can't hear you.
Renju Pradhan, can you please unmute yourself?
Unmute or mute.
I mean, mute yourself. I'm sorry.
Okay, so at that time, friends, if you are one of my caregivers in a team, what I would consider most important is to be free of pain and other symptoms. Physically, I have to be comfortable. If I am in pain or if I am vomiting away 37 times a day, I cannot be emotionally comfortable. So if we agree that the purpose of end-of-life care is not to prolong death by a few more hours, dying by a few more hours, then we can agree that the physical, mental, social, and spiritual comfort are the most important things.
Sir, Rajagopal sir, we do have a chat from Jayanta Kosh about a query.
One second.
It's costly and painful to continue with the life support. Why then is this practice so prevalent in LMICs as India?
Then I'll come into this a little more in detail presently about end-of-life care. It's more than a question. Jayanta's question is more an expression of anger or dissatisfaction of the way things are. The why of it is very complicated. We'll talk about it. Sangeet, can you present the next poll? So when you go to a hospital, what do you think is the duty of care of a healthcare provider? Not necessarily doctor, nurse, social worker, physiotherapist, anybody. What is the primary duty of care?
Let's start answering the poll.
Okay, maybe some people are not ready with the answer. The vast majority say it's to prevent and treat my suffering. It's also to treat any diseases. We are not disputing that. But let me show you how officially that duty is defined in our country. Can you stop the whole
Yes.
Sangeet?
Yes, sir.
So the duty of care officially in India is defined. Sorry. Can you see my screen now?
Yes.
Yes, sir. Yes.
This is the official definition of duty of care of the healthcare provider to mitigate suffering. Yes, it is to treat diseases and cure sometimes. Only 1/3 of all diseases are curable. Relieve often. Yes, a large number, diabetes, hypertension, and so many things can be controlled and comfort always. There exists no exception to this rule. So when you treat my suffering, you are fulfilling your primary responsibility. As part of that relief, diseases cannot be ignored. Certainly, diseases need to be treated, cured when possible, if not controlled. True. But always, suffering has to be mitigated. So, this official definition of our duty of care, Devika and I have to remember. This is our purpose. So, look at it from a nurse's point of view. If a person is bedbound, they are taught to change the position every 2 hours to reduce pressure source, to prevent pressure source. But when we know that it is the final day or final couple of days, when we think it is, maybe there will be a balance. Okay, sometimes you may allow it to be 4 hours if the person has not been sleeping all day, and finally at 2 o'clock in the morning they are sleeping. You wouldn't want to wake him up at 4 a.m. And maybe you will allow the person to sleep a little more. And another common issue, not only Geeta and Jayanta, but everybody who has gone through that experience in your family, know that you feel very, very uncomfortable when the person stops eating and when they stop drinking, particularly women who are who sometimes whole life they have been feeding people. And when a loved one starts refusing food, they become upset. But, dear friends, think of me in that bed. Please understand, in my last days, my body's metabolism drops. My need for water and food drops. And if you now push with the doctor's assistance, push a tube down my throat, that will make me uncomfortable. And if you fill my stomach, there is no purpose. It only causes me discomfort. Please remember, need for food drops. I would like everyone in this group, not only for end of life, always remember, forcing food on somebody with poor appetite does not improve anything. With treatment, if we restore the appetite and give enough food, that will be useful. If not, it will distend the stomach and make the person uncomfortable. So sometimes, nevertheless, especially in warm environments, when they stop drinking, they can get dehydrated, then may get fever and restless, or may get delirious. So if they are unable to drink, rather than intravenous fluids, which are the usual in hospitals, in palliative care, we give subcutaneous fluids. I don't know if somebody has talked about this as part of this course, but this cannot be just explained and given. It is no big deal. Many of you yourselves may be giving insulin to your loved ones subcutaneously. You don't need to be a doctor or nurse to do that. It is IV subcutaneous titration is not more complicated than that, but that's not our subject now. Particularly any doctor and nurse in the group, please remember, you may have seen it being done for half a century in the hospitals, but we have no knowledge. This is a resurgence of this from half a century back. So putting in tubes all over the place in somebody who is clearly dying is done only if it will improve a discomfort. For example, somebody has a block here and they say, I'm hungry, give me something. There is no other medicine except food. So then you may have to give the food. This Parthasarathi show was the former financial advisor to Prime Minister Manmohan Singh. About his mother's death, he wrote this article in 2016. Even his mother had an advanced liver disease and was dying. Even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was in the negative. They have already decided that the person is incurable and is an advanced stage of illness. And we continue those investigations. We continue those multivitamin tablets forced down the throat. Why the cholesterol medication being continued? We do continue to do invasive procedures and scanning and things. Just because we doctors have been taught to do those things, we continue to do it even when we know the person is dying. Remember, this is not done in Western countries, certainly not in European countries, where medicine is more advanced, where they can afford to give more expensive treatment. Well, if necessary, you may still give antibiotics to control a bad respiratory infection or a urinary infection which causes pain. But we'll avoid hospitalization if possible, and if it is essential, we will avoid an ICU for isolation, where people are isolated. Okay, they have a surgical problem. Will you also operate on them? Well, if we are only talking about end-of-life care, if that is needed for pain relief, we may still do it. Somebody with a distended abdomen which cannot be relieved may need a colostomy even in the last month of life, because otherwise that distension cannot be treated with any other medication. We may still give a radiate a bony metastasis if it gives pain, a single fraction palliative radiation, but not continued chemo up to the last day. And we will not put in any feeding tubes. If there is one already, that's another matter. But to someone we know is almost certainly dying, we will not do invasive procedures like intubations. Does anybody have a question about any of these or a comment?
You can also use the chat box to come up with your doubts and clarifications, if any.
Dr. Shivakumar Vishwanathan, are you a doctor? I don't know. Though I have had my share of personal losses, especially that of my father, I must say I became an emotional wreck witnessing over 500 plus deaths during COVID. Shivakumar, our discussion is to help people face those things. As a palliative care physician for 30 years, I too have seen a lot of deaths. And how you cope with that is by acknowledging that people will die and by providing palliative care. COVID was tremendous because for most people, except for a few people who attended our COVID courses and started giving palliative care to people, majority of people died in extreme suffering. That is the most painful part. Not just death, but dying in suffering, dying in isolation. Yes, indeed, that was a cruel time.
Sir, we have
Yes.
more chats from Jayanta Kush. There are a lot of confusion about feeding tubes. Can you please give some insight of the applicability? And from Geeta Nair, one patient cured is one customer lost. Do you think private hospitals in India follow this statement?
I think Geeta is partially answering Jayanta's question earlier. It is costly and painful to continue with life support. Why is this practice so prevalent? I think Geeta's question answers the other question. It is expensive. It's also more money to the healthcare provider, isn't it? Who wants inexpensive palliative care? About the feeding tube, Jayanta, we start thinking, what's our objective? What did we say was the objective of care? I mentioned it earlier. It is comfort for the person, comfort and peace, physical, social, and mental well-being. Is the feeding tube necessary for well-being? Usually it is put in for the benefit of the family because they start worrying, oh, my dad is not eating anything, he's not drinking. How? That's cruel. But if the person is not hungry, it is cruel to feed that person. Dying process does involve loss of hunger. But as I said, Jayant, if I am hungry and cannot swallow anything because of an obstruction here, then it is my choice. You give me the choice. If I am competent to take a decision. If not, my loved one will take, my next of kin will take a decision. If you are treating hunger, put in that. If not, in somebody dying, it is a cruel infliction of suffering. To put in the tube, to have the discomfort of a bloated tummy, and then also death being prolonged a little more.
So we do have one more chat from Ashwati
Yes.
Vijay, but starvation to death is another sin, right, sir?
Ashwati, is that your personal conviction or are you quoting somebody? No, another sin. Who says so? You feel so, right? Starvation to death. If my need for food, stops, where is the question of starvation? I am unable to use food anymore. That's what happens when people are dying. Your cells are dying. You are unable to process food. That's the first part of the answer. Secondly, a more philosophical and spiritual answer. By Indian practices, Ashwati, do you know of Santara and Sallekhana practiced in Jain custom? The two different sects call it Santara and Sallekhana. And have you heard about Prayopavesha in Hinduism? When somebody decides that your responsibilities in the world have been done, in Hindu and Jain practices, with the help of spiritual leaders, people gradually abstain from one food item after another. Please look up, I'll put up those terms in the chat box. I am not saying that I am recommending that. Salekhana, Santara, these are both from Jainism, and Prayopapesha is from Hinduism. So, where this is considered a spiritual practice and experience. Shivkumar, I am so sorry, I cannot afford to go to euthanasia except to, in terms of time, except to mention it in passing towards the end. I am not recommending euthanasia. No. We will come to that. I will mention the difference between what I am saying, that is ending life on naturally, natural end of life, and euthanasia. We will come to that. So we mentioned physical well-being, but also psychosocial spiritual support. If you have the time, please sit with me. Please sit with me. Maybe this is kind of thing is what Devika commonly does. Find out from my story. Just tell me about yourself. Tell me about your life. You may be surprised if you do this to your grandparents or parents. You may hear once you start, Papa, tell me about your childhood. Papa, tell me about your education. Tell me about your school. And as people tell their stories, we discover their values. You shouldn't be judgmental. You shouldn't say, oh, Papa, you shouldn't have done that. It's not for you. It was his life. It's lived without judgment. Listen to those stories. Validate feelings. I can see that you feel disappointed about those 20 years of your life. I acknowledge your grief about your feeling of not being loved. I see you are feeling guilty about the way your dad died. Acknowledge that. And acknowledge achievements. But I am amazed. You have given us all this, but you had nothing, and still you may become a success in many ways. I have admiration for that. Remember, spiritual support is not necessarily about reading to them from the Quran, the Bible, or the Gita. It's also about validating the human being, acknowledging their achievements, making the person feels, well, there are at least some parts of my life that were good. And sometimes, if the person stops for a minute, don't jump in. And why are you not speaking? As they tell their stories, there may be period of silences. Respect those silences. Stay there. Unless the person indicates that they are tired and want to end the conversation, don't get up and walk away as long as you can afford the time. And after maybe 5 minutes of silence, they may start talking. And then the real person will emerge. Then you will know the person. Then you will know what's important for that person. And then the person may say, but you see, I wish I had made peace with my brother. It is 10 years since I have talked to him. Or the person may say, I wish I could go back to my village. Just be there for 1 hour more. And many of these things you may be able to make possible. Or the person may say, I want last communion. I want to see a priest. Yes, that also. But that is an important part of end of life care. And friends, please remember, you don't have to wait till the end of life. If you have not had a meaningful conversation like this with your own loved ones, please find the time and do it. You will discover things that you never knew about your dad, mom, or even about your child. Sangeet?
Exactly, sir.
So the next poll has been shown, so you can start answering to the poll.
Devika,
Yes, sir.
I am not doing very well in terms of time, am I? How much time do I have?
So we have till 4:30.
No case presentation or anything?
No case presentation today, sir.
Okay. No, interesting. Many people feel very connected with their own home, especially towards the end of life. Those who work in hospitals would be familiar with this. Can we go home? Doctor, can I go home? Can I go home? And then the doctor will say, you will get discharged tomorrow. And at 4 o'clock, the person wakes up, has a shower, gets everything ready. By 5:30, the person is packed and ready to go home. And then there is a inevitable waiting for the bill, which comes only at 4:30 p.m. The person is very restless. Some people are attached to the home very much. Maybe the younger generation less so because you are used to moving around. But your grandparents maybe more so. Many people are connected to family more than anything else, and a lot of people are connected only by their faith, and more than anything else, they want to hand their lives over to God Almighty. It is rather unusual to hear 2-3 people saying your occupation. Yes, don't please, if anybody else is being judgmental about it, don't be. Because what they do, I am amazed that there are 3 people who love their jobs. They are not just doing it, they feel connected to it. They are doing something meaningful. Did something come up as the last option in the chat box?
Not
Devika?
till
No.
now, sir. But you
Okay.
can you also use the chat box if you have any other answer for it. Apart
So-
from home, family, occupation, you can
So
also use it.
friends, none of the answers is correct or incorrect. It's very person-centered. You see, when we are talking about yourself, it is so very different. And if you say it's always everybody is comfortable at home, that may not be correct. Many people may opt to be in hospital. I don't know if they were still there when my own professor was admitted to a palliative care clinic. She lives just 1.5 kilometers away, but she chose to be there. She chose to be there till her death, which took more than 3 weeks. Her son had come from USA, an oncologist from a very celebrated cancer hospital, and they lived there. He works from the hospital room, and our home is not exactly a 5-star place, but they live there. It's where they feel confident, connected. So none of the answers is right or wrong, but people feel connected. It's up to you and I to find out what that connection is. And those family connections may sometimes have been fractured. As I said, in the case of the brother to whom one has not spoken for 10 years because of a property dispute. And it's our job then, Devika would understand that. Once you find it out, listen, tell me, please give me permission. Let me talk to you, give me the number and let me talk to your brother. And then you may be able to see the brothers reuniting, connecting together, crying together. And that you will see giving great peace to the person. So the point of this poll is that the answers can be very different. It is different for different people. See, 23% of people, it's about faith or religion or God. And we have to make that possible. I have actually seen a hospital person refusing admission to a Catholic priest when the patient wanted last communion. I sort of opened the other door and took the priest without the consent of the person who was blocking it, because that was the most important person for that in that bed. You have to make it happen if there is a possibility. But if it is your family, that's your concern, you should not go there and force God on that person. That's that person's choice. These 23% people are connected. That doesn't mean that everybody else has a responsibility to feel that connection. We respect individual preferences and values. Your own spirituality is important, but just like you take your chappals off outside the door and walk into a sacred place, keep your own belief systems within you. Don't force it on me when I am in that bed. I am not even strong enough to ward you off. But go by my choices. Sometimes there may be unfinished business. Like you mentioned, 3 people said occupation, their job was important to them, where they connected. I had this man who was in great distress because he had a business in Mumbai. He was having advanced cancer. The one thing that he wanted was to go back to Mumbai for 2 weeks so that he could shut his business down, so that he could pay off employees, let them go, and leaving that business still there and not looked after was very hard for him to bear. I had to keep on persuading the daughter and son-in-law, please take him. That's the most important thing for him. And depending on the individual person, enabling religious practices, restoring broken relationships, like that brother, ensuring the presence of the family, which is not something that intensive care units are very good at, and building new connection. They may not have anybody. The connections may not be meaningful anymore. They may be broken. When somebody doesn't want interventions, a family refusing to let go and forcing all sorts of tubes and interventions on them, the connection may be broken. The person may be feeling, nobody understands me. I am all alone in this world. Please remember, this is very common. the spouse and the person has lived together for half a century. But at this point, the person with the illness is alone. That's why I said, you build a bridge. Sometime you may have to mend the broken relationship, but sometimes you may be the only person to whom he feels connected. At least one person understands me. Please do not underestimate the value of this, and please do not underestimate your own worth. More than somebody who knows scriptures and can recite them, your understanding may be much more valuable to a person. And particularly, our aim is not equal care. Our aim is equitable care. Give special attention to children who are forced into the position of caregivers. This is a cruel thing. Small kids sometimes end up as the sole caregivers. You and I together have a responsibility to take the position of that girl's parents and do the best for the caregiver also. And not only children as caregivers, all caregivers at the time of end of life for a loved one need attention. But there was question about the tubes and intensive care. Hey, who is going to read this out for me? Somebody? Vishnukumari? Manju? Zamina? Is one of you able to unmute and speak? Read this out for me? Sogi kya?
May I, sir?
Yes, please.
It's from the Hindu on 9/8/2016 by somebody Sindhu S. And it reads, my 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized.
I have given the link there. The article is still up on the Hindu website. I would recommend that all of you later read this article, The Cruel Face of Medicine. After that, on the last day of his life, one evening, Sindhu for the first time heard about palliative care. And she went and told him that I am going to take you away tomorrow morning. But early that morning, the father died. And she wrote this, poured her anguish out on this article. This is my worst nightmare, dear friends. There was this question about tubes being put in. Jayanta, if it is a person with delirium, dementia, they may go into delirium in an unfamiliar environment. Even otherwise, 1/3 of all people admitted to ICUs and 2/3 of all elders admitted to ICUs get delirious. They won't be able to be in control of their faculties. And if you put in a tube, they pull it out. So what do hospitals do? Tie them up. What a cruel way to go from this world. Compare that with a kiss and a hug. Arms tied up, unable to move. If their back hurts, they are not even able to turn to another side. There is a clear advice. I don't know if you know about the National Cancer Grid. That's a collaborative of more than 300 cancer hospitals in the country. And together they have this guideline. So if your oncologist advises intensive care unit for a person dying of cancer, please show him or her this. Do not treat patients with advanced metastatic cancer in ICU unless there is an acutely reversible event. The whole article is published in the Lancet Oncology, and it's available for free access. I have given the link there. So this is the official recommendation. What happens in those 300 hospitals, don't ask me. Now, I am asked with all this, when I asked about the no tubes unless necessary for hunger, when I mentioned no intravenous fluids, give subcutaneous fluids, some of you have been wondering, am I advocating euthanasia? By no means. It's not a question of whether I think euthanasia is right or wrong. It is illegal in our country. No question. But we are not talking about this. We are only allowing natural death. We are disallowing artificial interventions. Allowing natural death and euthanasia are different. Euthanasia is killing. In euthanasia, you intervene to end a life. But giving a kiss and a hug and allowing your loved one to go, how can that be killing? That is the distinction. Now, in a Supreme Court judgment, they use the word passive euthanasia for withdrawal life support. That's a misnomer. I earlier mentioned the duty of care of the healthcare provider. This is the same document. This document clearly lays this down. The term passive euthanasia is a misnomer. Euthanasia cannot be passive. In euthanasia, there's an action, some action. It may be by injection of potassium chloride and other things into the vein. It may be opening an infusion and giving lethal medicines, whatever it is. Euthanasia involves killing, with good intention. Intention is to reduce suffering, but it's still killing. Ladies and gentlemen, we are not recommending euthanasia. Euthanasia is illegal in the country. There's no question. Euthanasia today will be murder. We are not talking about that. I hope you are able to get the distinction between allowing a natural death when it's inevitable and actively doing something for killing somebody. So, to the people who have experienced this, and to the 50% of people who are able to think about your own death, please make an advance directive. You have to. That page in our website gives the format. India does not have a law governing end of life. In the absence of law, Supreme Court judgments holds valid. Earlier this year, January 2023, the judgment is available on our website. It is you writing that down to protect yourself. Jayanta wishes that his father was home, but it was not possible. For all of you who are able to think about it, you need protection. You may have some money in the pocket. The poor people die better. The rich die in misery on ventilators. Protect yourself. Fill up an advance directive form. Also, hand over the decision making to somebody else at a time when you are incompetent to take your own decision. If I am not in full possession of my faculties, if I am delirious, if I am confused, if I am drowsy, okay, so and so will take a decision. But the most important part of a advance directive is talking to your family first. They have to be on your side. Whatever you have written down holds no value unless the family agrees, because legally, yes, what you have written down is valuable. But any doctor will have the sense to see that dead people do not go to court. Living relatives go to court. So what I did was, after writing my advance directives, I showed it to my wife. I got her consent. I talked to my 2 children. One did not want to talk about it. It took me some time, but I was patient. I eventually convinced him. Now both of you have agreed that they will go by my advance directive, which I have written, kept with me in my medical file, which says that in the event of me having such and such and such a kind of disease from which there is no reasonable chance of recovery to reasonable quality of life, I refuse all life-sustaining interventions. I opt for palliative care. And if my situation is such that I cannot be taken care of in my own home, I should be admitted to a palliative care center. I certainly decline life-prolonging interventions in such an event. The court has permitted it, but the court also, though it has simplified a previous Supreme Court verdict, they still have some problems, like they call withholding, this WWLS is withholding and withdrawing life support. They use the term passive euthanasia, so that many religious organizations have major objection to this. Not only that, they have put in some impractical procedures, like the hospital has to appoint a board of doctors. Okay, can be done in a few hours. Then has to inform the DMO, has to have a second board, which may take 2 days for a decision. So, which is why the advance directive is all the more important. Once you put somebody on life support systems, the doctors may be reluctant to withdraw it for a variety of reasons. One of the reasons was hinted at, the financial aspect of it, of hospitals. But also doctors genuinely feeling that they have a duty to prolong life. So please create the documents. See the bottom. This website gives a sample. You can take it, make any modifications that you like, sign it, witness it, inform your next of kin, give a copy to them, and get it countersigned by a gazetted officer. Bas, ho gaya kaam. So, we talked about all this. You are among a tiny minority of Indians who have discussed this subject, right? Death is today a stranger. In my generation, death was part of life. Cattle died in the cattle sheds, relatives, old people died in the home. That was it. We were all familiar with it. We grew up accepting death as a natural process. But today, I don't know if Sangeet has ever seen a death. So, the Lancet Commission report recommends that there should be new literacy on dying. People have to be able to talk about it the way we are talking about it. Health care students have to learn it. Social care students have to learn it. Practicing professionals have to learn it as a new subject. And we as palliative care providers should provide our patients with clear information. Uncertainties as well as potential benefits, risks, and harms of interventions in potentially life-limiting illness so that they can take more informed decisions. How much should we tell them? It's decided by them, as much as they want to know. Unfortunately, personally, I believe the biggest barrier to proper end-of-life care is the doctors genuinely believing, of this generation, genuinely believing that they have a duty to prolong life at all costs. Friends, I have been a doctor for a long time. Till about a quarter of a century back, till the end of 1990s, this disease was not there. People died decent deaths. Okay, no palliative care, but they died in their homes or in the hospital wards. This business of incarcerating every dying person in intensive care unit is a new disease which just happened only in the last 25 years. And within that time, new doctors genuinely believe they have a duty to prolong life at all costs. And even the family's generally attitude has changed. Instead of accepting death as a natural consequence of the life, now the loving daughter's or son's reaction is, I can't live without my mom. I can't let her go. That is selfish kind of love. The unselfish kind of love would be, my mom is suffering. Her time has come. Let her go in peace. And also the societal factors. Just the use of passive euthanasia by Supreme Court immediately drew an angry reaction from at least one major religious group. They defied the court just because the term is used. And of course, there is lack of legal clarity. There's no law. It's only the Supreme Court judgment and where all those processes and procedures have come in. So there are barriers, but we have a responsibility. This is precisely the reason why at the end of life, people should have access to palliative care, because the conventional medical system may not respect humanity and a human being's dignity. I see that we have some 12 minutes more for discussion. I'll keep the presentation with me so that I can go back to it if you have a question about any of this. But I'm happy now to take in questions. People who have not spoken so far, so many of you, you have the first chance. Hey, Sangeet, do all these people actually, are they there behind these black rectangles? Or have they gone for tea? Hello?
Am I audible, sir?
Yes, Prince.
Sir,
Prince, where are
actually,
you from?
yeah, I'm from Mumbai. And
Prince, are you the palliative care physician, Prince?
I am actually a counselor in
Okay.
Romila Palliative Care, Mumbai.
Okay, Prince.
So this is regarding something I attended today. Actually, I had gone to visit a person. She is suffering from cancer pancreas. And I was having a time, I was sitting and having a conversation with the doctor. And she is in acceptance of her mother's condition. But she's very much emotionally weak. Even though she says, I'm strong, I understand, I'm prepared. But through our conversations, I realized that is not the case. But to a point, I was also feeling very confused of how should I help her out. Uh, I would actually like to get some insights of yours.
No, the problem is I do not know the details. I'll be glad to get on a call with you to get the details. But
Sure.
being in acceptance
Hmm.
doesn't mean that the person is happy. How can they
Yes.
be? They will be
Correct.
unhappy. They'll be very sad. So when they are in acceptance, they are in grief. They have to go through the grief. And the grieving people sometimes can go into clinical depression also. So let us not, thank you for raising that point, Prince. Let us not think that being in acceptance means being happy. Being in acceptance only means that you are better able to make the right choices for the dying person. But you still live with your grief. You heard Jayanta and Geeta.
Yes.
It is not as if after 6 to 9 months, everybody is forgotten. Every lost person is forgotten. The hole, if the departed person has left a hole in a life, that hole is never filled. You learn to live with it, that's all. So, Prince, I am very glad to hear that you spend the time with that girl. If they thought she was very glad, the best you can do is to have more time with her, to make her feel that if she feels desperate, there is somebody to reach out to. And if she has signs of clinical depression, only then that's get treated. And when the mom dies, she will be devastated because she is suffering love. She is suffering from anticipatory grief.
Yes.
And except for her going through the grief, there is no other way. You cannot take that grief away. She needs the grief gradually to rebuild her life around that gap. And she needs a hand to hold on to. And that hand, Prince, you have the privilege of offering the hands. And we, all of us in palliative care, have that privilege of helping somebody through the most difficult time of their lives just by being there. Sometimes being silent for 10 minutes and just sitting there. Sometimes just holding a hand. Sometimes wiping a tear. But you cannot take the grief away. You cannot. You can only be companion in that grief.
Yes.
Prince, am I making sense?
Yes, sir. Very much. Thank you so much, sir. Thank you so much.
So, Prince, now I am convinced that it is not a blank rectangle. There's really a person behind it. Thank you for speaking out.
So sorry, sir. I was actually traveling. I was traveling
That's
from
fine. That's fine. I understand. So, Kavita, Anam, Trisha, Deepthi.
Sir, good evening. This is Abhilash Praveen.
Yes, Abhilash.
Tenkasi.
Tenkasi, okay.
So
we will meet up someday.
Yes, thank you, sir. Thank you for So last week, as you know, it was my wife's first year death anniversary. And since I met Pallium and formed a new palliative care service in the month of May. And even before that, since after my wife passed away, talking to people about death or even about palliative care, I'm finding it very difficult. Like people are not ready to accept even the conversation of palliative care or death. They just want to somehow, they just want to live. They just want their loved ones to live. They don't want to even talk about it. It is like moving a mountain to bring awareness about palliative care here. And I just wanted to tell you, it has been a very difficult time. Some people even, I have seen that they feel that since I lost my wife, they are thinking that I'm talking like this because I lost my wife. So I don't know, like I don't know how to say that, but they are thinking that I want everyone to accept death because I lost my wife, but that is not true. So yes, sir. So it is very difficult to talk about death or palliative care.
So I'll, with your permission, Sangeet and Devika,
So,
I am sharing one more screen just to answer Abhilash Praveen's question. Abhilash, as I already mentioned earlier, we are now a death-denying society. A whole generation has been grown, two generations have grown without seeing death. Death is a stranger. What you are trying to do is to make a major change, huge change. And when you do, you will find for any change, there will be only a few people who are ready and willing to listen. You are called, your first name is Abhilash or Praveen?
First name is Abhilash, sir. Abhilash Praveen.
Okay, Abhilash. You said the people are not willing to listen. But haven't you found a few people who are willing to listen?
Yes, definitely, sir. Few are
there. See, that is natural, Abhilash. You must be prepared for that. You particularly, because you are pioneer in Tenkashi, where palliative care is unknown, where death and dying is not talked about. You will find only these people. Some people may even be angry. Hey, don't talk about inauspicious things. Never come here anymore. Majority of people will be indifferent. They will think, okay, just because he is suffering from depression because of his wife's death, they may say this. But please remember, you keep working with the ready and gradually things will change. The line will shift. Gradually, more and more people from here will join you. Because you and I have a duty to do this. Because we know that here is a huge problem that those people are not ready to face. They are unwilling to accept it. And therefore, we will have to be patient. Abhilash. And you are doing what we should be doing. You are connecting with my colleagues because we need to be together. You can't fight this whole bunch of people by yourself. We need to be together. And gradually, when we keep trying without fighting, let us use the Gandhian principle, non-violent agitation. We won't go and fight them, but we'll keep working. And then you will see the change happening. We have seen that in Kerala. I know it has taken 30 years, but it is changing. And the change will be gradual. But there will be nobody else to do it in Tenkashi if you don't do it, Abhilash. So that's all the more important.
Sir, I would like to add some point. So, Abhilash sir is actually a very passionate worker in palliative care. He is actually working in IT field, but he is about to start. He is on the process of starting a new palliative care at Tenkashi, and he has also come to Pallium India for observation trip or for a day. And yes, so I would like to add that also. So along with his IT field, he's also trying to help people in Tenkashi as he knows that there are no palliative care centers in Tenkashi. So he's trying his best to establish it in his place.
I heard about you already. Devika, I was told about Abhilash and we are in correspondence.
Oh, okay, sir. Okay. Yeah.
Last week, we had 6 days awareness programs in different places in Tenkasi, sir. From 9th October to 14th October, Lalit was here full time. Dr. also was here.
Okay.
Thank you.
Thank you, Vilash. Thank you for what you are doing. Devika, I know time is up, but will you permit one more question to be answered?
Sure, sir, sure.
Earlier I had written down the name of those Jain and Hindu practices, Sallekkhana, Santara, and Prayogavesha. If anybody wants to study more about it by Googling. So, Mr. Shivakumar Vishwanathan, with your permission, shall I mention the gist of your message, Mr. Shivakumar? Mr. Shivakumar, you want to set up palliative care centers. My recommendation is start with one. I've seen this happening. Somebody wants to set up a chain, and then it turns out to be too much. It's a too big a change. So certainly, Mr. Shomar, we would welcome your visit to Trivandrum. We'll find a time to talk. But Devika, get Mr. Shivakumar's, you must be having Mr. Shivakumar's contact information. Please connect them also to, which city are you in, Mr. Shivakumar? Bijapur. Okay. So we'll also, Devika, please connect him to Shalini.
Yes, sir. Yes, sir. Sure.
I suppose, I don't know whether it's Sunanda or somebody else taking care of that area, Bijapur. But he has put in his phone number also. Thank you, Mr. Shivakumar. And we'll certainly meet up when you come to Trivandrum. But certainly be in touch with our team also. We have a bunch of people trying to help people who have the wish to start palliative care services.
Sir, we've already connected to Lalit.
Okay. For whom?
Shivakumar.
Sorry, Mr. Shivakumar, pardon my geographical ignorance. Which state is Bijapur in? Karnataka. Oh, it is Lalit, right? Okay.
Yes, yes, sir.
Right. Okay. Certainly. Okay. I have exceeded time. Devika gets very violently angry if I exceed time, I must tell you. Really scared of what will happen now. Thank you for the questions and thank you for the interaction. Devika?
So if you have any more doubts or clarification, you can use the mail ID and you can mail the doubts. So thank you so much, sir. Thank you so much for a wonderful session, and thank you everyone for attending the session. So over to Sangeet.
Thank you, sir. That was a very informative session. Thank you. Thank you everyone for participating. Thank you everyone. Let's see in the next section. Thank you. Bye.